So I have the pleasure of being an executive sponsor with our OHT around a collaborative quality improvement plan focusing on cervical screening. We knew that we already going into the pandemic had lower cervical screening rates than other areas in the province. And yet we really saw this impacted during the pandemic. We knew though that the interventions needed to really be tailored to understand the communities, and that's what we're talking about today. So just a little background. We took the opportunity to look at all the really great data that existed provincially to try and understand the problem. We were able to zone in and look at specific postal code areas where we were seeing difference in access to services, seeing difference in breaking down barriers to care. So you can see on this slide, we had the opportunity in our OHT, as Melissa has talked about, it doesn't take one provider, it takes all providers. And so we started to looking at where there was synergy or intersectionality of providers that were already in certain communities, had some trusted relationships, but also needed a focus. So the four postal codes on the screen were areas that we wanted to target in order to improve care delivery. So we set a bold and ambitious partnership. Some of the comments that have been in the chat, Wellfort, that I have the privilege to be the CEO of, is a community health center here in Peel Region. We work closely with our Rexdale Community Health Center, as well as other family health teams and other primary care practices. The three of us, as three primary care organizations, said we're coming together to actually tackle this problem together and really look at strengthening community-based care. This took a leadership hat that said, I'm not only going to improve the care inside the walls of where we're delivering primary care, but we're going to take on that increased accountability and responsibility to support the entire population area within our geographies. It also created the opportunity to challenge ourselves to say, how do we use our EMRs? How do we embed data collection consistently? And for my ministry colleagues and other researchers, I think the mic drop moment is we don't collect data the same way. And so this was an opportunity to come together and say, we're going to change that so we really understand the needs in our community and our population. The intervention that we focused on really highlights that some of those components that Sarah shared with us at the beginning of principles. We knew that there was the individual inside the walls of a clinic and how people had access to cervical screening, but there was more than that. There was also that population health perspective. And we leveraged elements of high priority community strategy that was underway in this province, as well as the collaborative QUIP and that shared commitment in this OHT to say, we're going to focus on that clinical perspective, which you can see in these blue spokes that are moving about. And that's everything from understanding how we're funded in primary care, to how we put data in our EMR, to how we pull data out of our EMR, whether people have OHIP coverage or not, and all those kinds of elements were moving parts. But in addition, we wanted it to be more community-centric. And so understanding what are the barriers if someone is unattached to primary care? What is the barrier if they can't get transportation, if they can't get childcare? So when I talk about being ambitious, we knew that we were trying to tackle all of these things at once, but using the leverage of strong initiatives that were in this province at the time to bring together an intervention. When I think about Sarah's overview, we tackled the connectedness of different programs and funding opportunities. We looked at the intersectionality of some of these elements. We created a flexible approach to care, and the other pieces, we're not finished yet, still got 6 months to go, so lots of exciting pieces. We also leveraged things like a mobile health outreach approach. So similar to Melissa's comment about the clinics, it's bringing those clinics close to people's homes and created the trusting relationships. So the actual intervention of our future state has these components. The commitment to measuring cervical cancer screening the same way across all providers. We're starting with our 3 primary care practices now, also working with the EMR vendors to talk about how can we continue to leverage this. we believe we're going to have more real-time data for these targeted postal codes than the ministry will be able to have. And it'll be at our fingertips, and the kinds of interventions we'll be able to watch what happens with our data. We also are committed to breaking down those structural access, cultural components, all the things we're talking about here about inequities, and really make sure we break down those barriers. We're also going to, out of this, standardize the cervical screening process. We talk from everything from health promotion all the way through to, if someone is diagnosed, how are we going to support them and treat them? We also knew, and to some of the comments in the chat, I want to do a shameless plug for your community health centers in this province. If they're not strongly engaged in your OHTs, I strongly encourage you to bring them to the table. The CHC model has been doing focused work on equity deserving populations for many, many years, with lots of research and lots of demonstration of outcomes. We knew that in our practices, we could collect socio-demographic data and pull it out. That was going to serve the inside the walls. But what about the population who is part of our OHT, but wasn't attached necessarily to our primary care practitioners? We now have both data collected from a population health perspective of these folks in these postal codes that we're supporting, as well as our inside the wall primary care data. And now as an OHT, we can better understand where the gaps are and what we need to do for interventions. Really quickly as I close off, that component of really allowing the community to co-design and give their voices, this is the work that we've been embedding our high priority community strategy team members in really getting out there and understanding. And I'll leave it as a teaser. We now know what some of the barriers are that help people have access to cervical screening, and we're creating cervical screening initiatives that tackle that. And last but not least, just to leave you as the summary of some of the screening and the lessons we've learned so far. We need to do that Western medicine approach to standardizing clinical practice for sure. And by coming together as 3 primary care practices, we're really starting to advance that now and have some aha moments about different populations and segmenting care. But we also know that data collection, including both clinical and sociodemographic data, is really important to our OHT to advance population health. We also really need to understand these neighborhoods. And so listening to communities and understand the equities that exist and what the unattachment rates do to how people access care from a primary care perspective has been foundational for us. And last but not least, we're going to increase those clinical access elements to improve population health. Thanks, and I'll turn it over to Terrence to talk a little bit about a couple of the other nuggets.
Awesome, thank you. So I'll speed through this. I'm not going to go through all the details. Another example we're going to be talking about today is the mammogram programs and engaging the ACB community. So since February, we've been working with the local hospital in Wellesley to create a program where we can support people to get access to mammograms. But before that happened, we realized we also needed to educate. We needed to address some concerns and fears and myths, and address other needs like food security and things like that, because there's many aspects of a person's identity. So this program was very small in group settings, and it happens weekly. And it allows folks to address some of their concerns, answer some of their questions, fears, things like that. And in the group itself, created a little sense of peer support as well. And so it's been a great program. So some of the folks that we've engaged, ACB has mentioned, if y'all don't know the acronym, there it is. Age group 50 to 74, last mammogram 2 years, no previous breast cancer implants, OHIP, no HIP, you got all that jazz there. So we did have some set criteria. So again, I'm not going to read through all this, but there was a process in regards to accessing this program. The screening by the nurse practitioner, and then requisitions and the appointments. And we actually went with the clients who were scheduled that day to the appointment, so they weren't going alone. And we initially had done, after the screening, a lunch plan where we could have a debrief and over meal. Debrief still happens now, but they actually much preferred having a gift card because they like to purchase groceries, as we're addressing food security. So it makes more sense to spread out those dollars doing some grocery shopping for the family versus a meal, since things are so expensive right now, inflation, everything too. So that's where we've gotten to that, or that's what we do in that program. So you'll see just some breakdown in numbers and what we've been able to achieve. 119 screened, 127 are up to date on their screening, and we've had 3 abnormal results. We do have some testimonials you can see. In addition to this, we also have what's called Be Well clinics. I don't know if you've heard of those. I don't believe we have a slide on that, but I just want to touch upon it. It's these community clinics where they started as clinics and now they're like events. We have not just clinics, we also have social services, we have entertainment, we have African food basket, we're giving out fresh food, food security, we have physical activity, we have just a gambit of things. We even have folks from the community coming in and telling their stories to hear from each other and some lived experiences. It's just really a community event, which started to be monthly. Now we're going to move to quarterly, but we are going to maintain. They're called the Be Well clinics, and they're geared specifically for the ACB community, created by the ACB community. All our community partners are all ACB from the community, as well as organizations that service the ACB community, whether it's locally within our geographical area or citywide. We meet weekly to design, plan, leverage, evaluate all that. And this has also been an evolution where now we're working with Black Health Alliance and Health Commons and BPO, Black Physicians Association of Ontario, to try to capture not just what we're doing, but the impact of it, to try to advocate for some of the needs of the ACB community in regards to this. The other last bit is we have with Black Creek Community Health Center, we have a mobile clinic coming in. So when the pandemic hit, and y'all been talking great about this and using the client-centered approach, pandemic hit, a lot of folks that weren't from the community didn't know that these things were happening, although we could have told you well in advance that this is going to happen. And we had to do a lot of education and advocacy for the needs of the community. One of those was accessibility needs, having clinics that were more accessible to the community. So we created those pop-up clinics for the vaccines. So that actually ended up leading into the conversations in regards to healthcare in general and how to make it more accessible. So we're going to have mobile clinics that'll be happening soon. We have an actual bus, like a van, that will be offering primary care and bringing physically to the communities and offering that. So right now we're in the communities getting surveys. I think we've done over 500 between Black Creek and Rexdale so far to find out from the ACB community what kind of services they would like, how we could engage them, what are the things they'd like to see in regards to it. So that's where we're at with that right now.